Hey y'all, I'm Sunny Shell, and tonight Bree and I are talking about the science of gender identity featuring Dr. Ben. So sit back, buckle up, and let's get to the sunny spot on Skeptic Haven. Hey everyone. Bree, you look so beautiful tonight.
Well, half beautiful anyway. Trying to do something different with my hair.
It looks
Yeah.
very, very good. Very good.
All right. Yeah. Hey, Ben, it's been a minute. How have you been? How was the move?
It was a long trip across the country, and I started residency about 3 weeks ago. So it's been kind of hectic, but we're slowly getting used to things.
Well, congratulations. We're so excited for you.
Yeah, thanks. Thanks. It's been
You're
great.
you're all grown up, going off onto your own.
I am a child that has now been given a lot of responsibility. So it's scary, but we keep getting reminded that we've done the work to get here and we know some things, and occasionally I'm surprised by the things that I know, but most of the time it's just mostly panic. But I mean that's what intern year is for, so we'll get there.
Yeah.
Yep.
So, as your trivia answers, have they been the secret key for any of your medical mysteries that you've got handed so far?
Oh no, but it's really funny because actually my co-interns, they're all at trivia right now at like a live trivia event.
Oh,
So they all love trivia, but I haven't been able to go because I've been doing shows and things on Thursdays. So it's fine. We have our own. I guess shameless plug for my trivia nights on Fridays. I don't even know if we're having trivia night tomorrow. We'll find out how tired I am at the end of the day. But
Well, I want to thank you for coming on. You know that I always enjoy talking with you and having you on the show. But I know you are very, very busy now. So I just want to thank you for taking the time to come and talk to us about this topic. And tonight we're talking about the science of gender identity. And so I kind of wanted to start off. And well, let me first say to everyone these are questions that people commonly hear from people who don't know, from cisgendered people who just don't know. And so keep that in mind. Dr. Ben will let us know if it's a question that you should not ask someone out in the real world. This is a safe place here to ask questions, but it's not necessarily a safe thing, or not a safe thing. It's not necessarily an appropriate thing to ask in the real world. So I just wanted to kind of give that disclaimer. And Dr. Ben, you will tell me if that is like, hey, don't ever say that crap.
oh, absolutely, I will be honest with people because I'd rather you take the time here and like ask the wrong question or whatever in a place where someone's not going to be bothered by it, instead of possibly ruining a relationship with a friend or a family member because you didn't understand. And it's not your fault necessarily that you didn't know something, and you can't be blamed because you didn't know something. But it is important that we take the time to learn and address those things before they become problematic, so that you can maintain those relationships with everyone that you want to maintain relationships with. So a lot of things are open for conversation tonight, and I'll let you know kind of which ones you're probably safe with and which ones just maybe keep to these kinds of spaces.
Absolutely. And it's also important to note that no one is obligated to answer anything, or to, you know, just because a person is trans or Hispanic or lesbian or whatever, they're not obligated to teach cisgendered people anything. It's not their job. So I just wanted to make that clear. Unless it's something like here where that's the purpose of this. Okay, so let's start out with our very first question. What is the difference between sex and gender?
All right, so this is kind of going to open a can of worms that is probably going to carry over into some other questions that we've gotten. So I'll probably lay it all out here and then kind of add some nuances as we get into those other questions, maybe. So I kind of put these in multiple different categories. So there, when we think of, because it's wild, like when you are first taught this in society, you kind of think of it as this dichotomy of, well, you think of it as one thing initially of sex and gender, and then you think of it as a dichotomy of sex versus gender, and then you kind of break this down further into more components as you figure out what defines you to be what. So we have your sex, which is your biological factors, which many people assume to be all one thing, which is not always true, because I view the definition, and I think many biologists are taking the approach of it is a combination of biological traits. So not just saying there's one key factor that makes you male or female. Like you'll talk to gender criticals on Twitter and they will say it is your chromosomes and that's the end all be all trait, or they'll say it's your anatomy, that's the end all be all trait. Yeah. But I would say there's no end all be all trait. There's no keystone factor that's going to make you more one or more the other. It is a combination of factors that contributes to your biological sex, which will be your chromosomes are part of it. So if you're XY, XX, XXX, XXY, any combination there, you can have even 4 or 5 X chromosomes. That's not unheard of. Kind of the one that you might not really see is just a Y chromosome, because that's considered to be a lethal mutation. So you're probably not going to see a live baby that's only Y. But any other combination you'll probably see. So that's your genotype or your genotypic sex. And then you have on top of that is your phenotype, which can even be broken down further into internal phenotype versus external phenotype. So, and that's based more on embryology. So it seems a bit sticky, because something even like the prostate, which you think of as being internal, is actually external because of the process it undergoes. So you have your internal anatomy, like the uterus, and those kinds of things. The testes, ovaries are all internal anatomy, and that's a separate category of sex. And then you have the external anatomy, which can be totally different than your internal anatomy. So that's why I separate them out. And then you can have your hormonal sex, which is also different. And a lot of people will say that your sex cannot change, but that's when they're saying that they're probably talking about your chromosomes. And no, I can't change my chromosomes, but
your phenotype,
you can change your phenotype and you can change your hormones. And a lot of the anatomy is based on hormonal sex. So that's kind of a more nuanced conversation, because yeah, I can't change chromosomes, but I can change other things. So if we look at it as a combination, there are certain sex aspects that you can modify. So that's a bit more if you're thinking of the hard science in quotes, I'm going to say, because we have some people that will say the hard science is what really matters and they're not going to care about social sciences, but we need all of these factors together. So that's just the biological side of the coin. And then moving on to gender, we have your gender identity, which is how you see yourself. This is a psychological phenomenon with your sense of self. And I'm not a psychologist, so I'm not going to go as in depth on that particular area, but this is how you see your own personal identity. And then there's also like just gender in general, which is a sociological concept with how you relate to the world around you based on reproduction and that kind of anatomy, which gets into some really sticky areas, because although we want to get rid of gender roles and gender stereotypes, like I think many of us would agree that those things are not desirable for a humanistic society. We can't necessarily get rid of them entirely, and we know that society has been formed based on a hierarchy of masculinity versus femininity, and how do we make a hierarchy of your reproductive traits? So based on how I view your anatomy, how I view your expression, how do I put you on a hierarchy based on that? And that's how we get sociological, like the structure of gender. And so that's where we get into some weird areas, because you have your identity on the one hand, but then you have the social structure that you need to fit. And so while many people don't necessarily want to fit in the social structure or need to fit in that, we often have to, because otherwise our gender is seen as illegitimate in general in society, because we're not able to utilize the terminology and the expression and identity that we would normally have. So that's where it gets really sticky with what we have to compromise for society. And I'll kind of get into some of those nuances later, but that's kind of the basics of differentiating sex versus gender.
That is, well, I just such a very comprehensive but very much needed answer. Thank you so much. I knew it was going to be long, and it very much needed. But we also have, it kind of flows into this question, the relationship between gender identity and sexual orientation. So what is that relationship?
Right, and there is some overlap here, which is very interesting, but it's not what people really think of, because your gender identity is how you see yourself in society and as a person with regard to being male, female, or anywhere in between, agender, bigender, etc. All of the variety of genders that you can be. And then your sexual orientation is who you are sexually attracted to. And then along with that, there's your romantic attraction, which who you might be romantically attracted to, but not want to have sexual relations with. And that's totally separate for the most part, because your gender identity does not determine who you are wanting to have relations with. It can be influenced by it based on certain sexual roles that you prefer to have. Like for me, one of my manifestations of gender dysphoria was with sexual compatibility with somebody, in that like my body, I wanted my body to have certain functions that it didn't have. And so that was a source of dysphoria for me, which is not sexual orientation necessarily, but it relates to how you see yourself in a sexual relationship, which could contribute, but they're still separate entities. But with that, like going into some more nuanced areas, I know some people might not be ready to approach this area of conversation quite yet, but if you're wanting kind of further steps on how these all relate, when we think about masculinity in a patriarchal society, we often forget that there's a lot of hierarchy even among masculine people within a masculine society. So when we're talking about something like hegemonic masculinity, so like what are the expectations of being a man in society, you notice that sexuality is something that puts you lower or higher on this social hierarchy within masculinity. So if you have a heterosexual male, you're going to have more social capital and be able to be seen as more masculine than if you're a homosexual male, or if you are a bisexual, or anything divergent from the norm in that society. You're going to have lower social capital and lower status. Mm-hmm. So that's kind of where we see it's not the same thing, but you do see some similar societal oppression, because oftentimes people with a sexual orientation other than heterosexual may be treated the same as somebody who presents feminine, which is kind of an interesting nuance.
Yeah, that is. All right. So how then does one respectfully ask about gender identity and sexual orientation? Or can they?
Yeah, I think gender identity is probably easier to ask about, because I mean, and you don't have to prod a whole lot. Like you don't have to ask the person like, what were you assigned at birth? What anatomy do you have? You don't have to ask those questions. And we should normalize this for everybody. Like one thing that's going around is asking your pronouns, which is a very, it's a pretty easy way to get to know somebody and where their identity is. It's not going to necessarily tell you their exact identity, because let's say you ask somebody and they say their pronouns are they, them, that doesn't necessarily mean that they're non-binary. Even it doesn't mean they have a particular gender identity. It just means that that's how they prefer to be addressed in conversation. So it is also important, like when you ask that, you're not assuming that because somebody uses he, him, or they, them, or she, her, that they are a binary person of that gender. So still be flexible, but probably the easiest way to ease into that conversation is to ask, like, what should I call you? What pronouns do you use? And then they will probably reciprocate, and that's pretty easy. If you know the person better, that's maybe where you can, if the person consents to it, you can start asking questions like, if you're really curious, like, do you see yourself as a binary trans person, or a binary cis person, or a non-binary cis person? Like, you can start asking some more of those questions. Like, do you see yourself as a woman, as a man? Do you see yourself as something other than those two, somewhere in between, multiples, none of them? And I think, like, once you get to know somebody, they might be more willing to address some of those questions. Sexual orientation is less easy to talk about, simply because it's very invasive of a question, because it's kind of implying that you want to know how they want to have intercourse with somebody and like what partners they prefer, which if you're not wanting to be partners with that person, it's kind of weird to ask that and not really necessary. I think maybe sexual orientation is a conversation that you don't just ask somebody, unless if you're on a date with them, that's different. Like if you're pursuing a relationship, that's an appropriate conversation to have. But if you're just friends, like maybe just let that come out organically. If they want to share, then they'll share. If they don't, then they don't. But I don't think it's going to make much of a difference if you know who they're sexually into or not. But I will say this now, and we were talking about this backstage, and I'm going to probably say this multiple times, but with any question that you ask anybody, like, it's important that you get consent from the person that you're asking the question to, and it's going to be different depending on the person. Like, especially if you ask me or you ask Bree or Stephanie or other people on this channel, if you're in this space, we're more than happy to answer even kind of the more extreme questions, because that's what we aim to do. But if you're talking to your friend off the street or whatever, and you just ask them about what's in their pants, that's kind of weird. So there's certain questions that you should not ask those people. And even before you ask any question, because you just don't know, what kind of things bother them and what kind of things they're open about. So maybe like before you ask a question like that, ask them if it's okay to ask a question in that category. And if they say no, then just respectfully, like, it's not to be mean to you, like, and they're probably not going to end a friendship over you asking. They'll probably prefer you ask. But just know, like, hey, that's not an appropriate thing that they want to address. And then that's when you take something here or another channel where someone is okay answering those questions. And don't assume that because somebody said yes to one question, that they're going to say yes to other questions. So like, and even on different days, like if I had a rough day with like dealing with my family, I might not want to answer questions about dysphoria on that day. So I might tell you like, hey, now's not a great time. But like, just be respectful and treat it like if someone were to ask you an invasive question, like you'd probably want them to ask you first. And like if someone were to ask you about like how you get along with your family members or your religious trauma, like if someone asked you about your religious trauma, you might not want to tell anybody about that. So just think about something that's invasive for you and like, would I want someone asking me this? No, I probably want someone to ask me first. So definitely get consent. So that was a little bit of a tangent to address that, but very important to do so.
That's
No,
what
I
you're
think
here
it's-
for. We want we want tangents. Give us
That's
the
right.
long story.
That's right. And one thing I said behind the stage as well is just because you have a friend that is either transgender or a different race or culture or whatever, it's not their job to teach you anything. So I think sometimes people who live in privilege, the word went right out of my head, so excuse me, sorry about that. When people have privilege, they don't even see where they are privileged a lot of times. They just assume that you're here to answer all my questions and you're here to teach me and I can just ask you anything, and that's just not true. So it's the getting that consent and that respect, but also understanding that they don't have to tell you anything. It doesn't matter. It's their choice.
Yeah, and something else here too, like I wanted to touch on with that, is like, so I'm here, obviously I'm answering from my perspective, and I'll try to, if I've heard different things from different people, I'll try to include those opinions as well. But like, I don't speak for the whole trans community. I don't speak for Bree. I don't speak for anybody else. So there might be, especially with some of these more nuanced topics, like I might have an opinion that disagrees with a lot of people, and so like probably don't say, well, but Ben said this thing, so it's the end all be all. Like there's a discussion to be had here, and I'm just giving one point of view. But definitely it's okay if you want to ask for a second opinion and ask other people, and they might have a totally different opinion.
And we have different lived experiences as individuals, yet alone just being trans people. I mean, I transitioned really late in life, been transitioned younger. You know, we went the opposite directions on that, which I'll never understand, wanting testosterone, that icky sauce all up in you.
I'm the opposite, so.
Yeah. There you go. So we have it's more a comment, but I would really like to see what your response to it. Aunt Jer said the best, most revealing question I've heard is from Jordan Peterson. Ugh. If I don't know your gender, how do I know how to treat you? What is your response to this kind of a question?
Right, that's just blatant disrespect, because it's again going back to the hegemonic masculinity thing of like, this is how I'm a man, this is how you're a man or you're not a man, and I'm going to treat you based on this hierarchy that we've established, and I'm not going to deviate from that. It's just disrespectful, like
absolutely
on so many
And
levels.
We have to remember that Jordan Peterson comes from a position where he thinks that we should go back to women being treated like property, and
exactly.
like if a woman is raped, it's a property crime. He actually said that. He's like, oh, it worked so well back then. You know, when women were having the time of their lives back in the 19th century.
Oh,
Right.
even his
Famously
name.
a heyday for women.
Yeah, even seeing his name just gets me all. Okay, so this next question, we had quite an interesting discussion backstage, so I can't wait to put this one up. What are the differences, if any, in the biological and or neurological makeup of cisgender individuals compared to transgender individuals? And I cannot wait to hear your answer.
Yeah, so this is going to come across as a non-answer, because it kind of is, in that we don't have any biological or neurological markers of what makes somebody cis versus trans. And I think like there's preliminary data at best that suggests that there might be some like neurological processes that trans people have with related to their gender that they identify with compared to the one they were assigned. But it's very preliminary, and I don't know. Like, I'm skeptical of it just because of the idea that, like, and not so much that like there isn't any factor at all. I'd be willing to say that there might be some biological factor, some neurological factor that plays a part. But the problem is, what do we do with that information when we have it? And that's what I have an issue with. So let's say we did hypothetically find a marker of transness on your chromosomes, and like, what do we do with that? Is the goal then to medically treat somebody so they're not trans? Is the goal to commit eugenics and eliminate people that would be trans if we thought they were going to be? Or like another, probably the most realistic scenario that would arise from this is that you would have somebody that, let's say you're a psychologist or you're a physician, something that's treating people with gender dysphoria or gender non-conforming identities, and they they show up to your office and they say, hey, I'm trans, I would like to receive gender affirming care. And then you get a test that says, well, we didn't find this marker that makes you trans, therefore we're not going to give you this care. So that's a problem. And especially when we're talking about adults who have the full autonomy to make their own decisions, like, are we going to put more barriers to care and more gatekeeping to people that are able to make their own decisions? I don't think that's the right step. So even if we do have some biological differences, I'd rather we don't go down that route. Just because I think, and from anything medically, like, if we don't have a use for it, we don't really need to expend the effort or cause harm from it. And this is a case where we could cause harm. And other examples like this for people that want to say, well, but what about being objective with medicine? Well, a lot of medicine, for one, we take into account a lot of subjective data, and we take into account the well-being of the person that we're treating. So if somebody's going to have improved quality of life from gender affirming care, then the right choice is to do that. So even if it's not what you'd want to do for yourself, if that's going to provide somebody, even if, let's say, even if they don't have gender dysphoria, but they have, they get gender euphoria from presenting as their gender identity, even if you go from, let's say, like a 97% quality of life to 100% quality of life, that's still an improvement, right? Like, I think all of us can think of our own bodies, and you think of something small, even like if you have a cold, that like you're still mostly okay. You can still function, but you don't feel great. You wouldn't want that to be your everyday thing. So that's even a small quality of life improvement that you can make. And so it's not, I think people think of it as improvement being either they're suicidal or they're not. And that's like the spectra of gender affirming care. But that's not at all it. There's so many layers to this. And I think any improvement that we can get is beneficial. So like, if we take this and expand, like, let's take a viral infection, go back to that cold example. Like, objectively speaking, I could have a person that comes to my office with a cold, and I could get a test that tells you exactly what virus is causing your cold. But is that going to change what I do for that person? No. So then what's the point in getting you to pay for that test, to get all that unnecessary work, to have you go to another appointment? Like, what's the point? I'm going to treat you the exact same way. So that's the same thing with trans people. Like, I'm going to treat you the exact same way. I'm going to refer to you by the name you want to go by. I'm going to use your pronouns. I'm going to give you your gender affirming care. So why do I need to know the biological markers? And that's kind of my outlook on that.
So I wanted to add on to that just momentarily here, is that the treatments that are provided to trans people are not novel for trans people. Cis people, when it comes to gender affirming care, most of it is done for cis people. The treatments that a cis man goes through to help maintain his masculine physique, or a woman goes to make herself look as feminine as possible, those are the same treatments that trans people are asking, that we have access to as well. And to gatekeep that based on any kind of other biological marker is ridiculous. It's just it'd be a waste of resources to even try to police something at that level.
Absolutely.
Right.
I guess we couldn't give boob jobs to people, right? Because it's the same thing. I mean, it really is. Yeah. I do want to say really quickly, Aunt Jer, don't apologize for that. This is a safe place. And it was, if I thought that it was something really triggering, I wouldn't have put it up. And we appreciate very much your question. All right. Our next question. Are there any ongoing research studies or advancements in understanding transgender biology that you find particularly interesting or promising?
All right. So this isn't really, it's not really new. But I'm going to mention it because a lot of people here have not heard of these things, and they're arguments that you're going to see all over the internet. But there's a lot of discourse, especially recently, about trans women and breastfeeding. there's a lot of people saying that trans women can't do that, and if they do, it's not actual breast milk, it's just some body fluid of nondescript definition.
Talking about Naomi?
Yes, I'm talking about that particular scenario. But trans people on both sides of the coin can breastfeed, because our physiology can be different depending on our hormonal inputs. And in fact, cis men can lactate, and that's not an unheard of thing. It's actually pretty common to get galactorrhea in men with gynecomastia. So it's all hormonally driven. So when we think of embryology and where you are biologically male or female, you develop the genital tract from one process, and you develop breasts from a totally different pathway. And breast tissue is sex neutral for most of it. And you develop the initial ducts pretty early on in utero, and then the rest of it develops in puberty with estrogen influence. So if you have somebody, it doesn't matter what chromosomes they have, it doesn't matter what other anatomy they have, if you give them the right hormone input at the right stage, they're going to develop biologically identical breast tissue to a cis female. So kind of the big difference is like the when you intervene with that. So a trans woman that gets HRT and is able to lactate might have less milk production than a cis person because of the amount of ducts that can develop over that time frame. And with the lack of estrogen during puberty, their initial puberty, but you still get this, it's the exact same milk production. So it's not a different substance, it's the same product. So people that are disgusted by that really shouldn't be. And then on the flip side, a lot of trans men also choose to breastfeed, and they'll go off of testosterone to carry a pregnancy, and oftentimes they'll have to continue that to breastfeed so that they maintain their estrogen levels. But that's a totally normal thing. And that's kind of the biggest one I wanted to touch on here. It's nothing new, but I figured a lot of people hadn't heard about it.
So you just mentioned puberty. So I kind of wanted to skip ahead in our discussion, because I think this is like a big deal right now.
Yes.
It's become political, which is so ridiculous. But can you talk to us about what puberty blockers are and exactly what they do?
Yeah, this will be a little bit of a monologue.
Love the monologue. Yay.
Yeah. So puberty blockers, the brand name for the most common one is Lupron. The generic is Leuprolide. There are other compounds that can be used, but this is the most common one. They all kind of do the same mechanism. And that is, it's going to, of course, suppress puberty. But when we say blocker, that's kind of it's a misnomer, because we're not actually blocking puberty forever. We're just pausing it. We're pushing the pause button. And so the goal of this is to, like, if you have a child and you cannot do this before puberty starts, it has to be when you have to have a puberty to block. So we're talking out of the normal range, kind of 9 is the lower end, 12, 13 kind of being the upper end of when you'd start this. But it pushes the pause button for kids that say, hey, I don't know if I'm a trans person. I don't know if I'm a cis person. I don't know if I'm non-binary. I don't know my gender. Or maybe they have an idea of their gender, but they're too young to start hormone replacement therapy. And so what we do then is we put them on this puberty pauser, and this does a couple things. So it prevents their endogenous puberty from starting right then, and it can give them time to go talk to a psychotherapist and figure things out if they're not sure about the route that they're taking, or if they know that they want to go down a cross-sex hormone therapy, it can pause their puberty so that they can wait enough time to start hormone therapy and have it be within an appropriate time frame for their age. And this isn't a new thing at all. So we've been doing this for children with precocious puberty, which is any age younger than 8 that you're getting puberty, which you can see this even in toddlers. You can see this very, very young. Like, I mean, the big one is in in children assigned female, if you see breast growth, like as a toddler or as a young child, they're going to start the same medication because of you're not wanting to start puberty at a developmentally inappropriate age. So this isn't experimental by any means. And it's the same exact mechanism for trans people as it is for precocious puberty. But what it's going to do is you have this fun pathway between your pituitary gland, your hypothalamus, your pituitary gland, and then your gonads. And so they all communicate, and your adrenals are also going to be minimally involved as well. But they're all going to communicate. And you're going to get a hormone secreted from the hypothalamus that's going to go to the pituitary, which secretes another hormone, which then tells the ovaries or testes to make testosterone or estrogen or whatever your body is going to make, because we know biology can vary. So whatever hormones you're going to make, that's kind of the process. And then you're going to produce those. And then you produce kind of a normal amount. And then if you were to produce a significant amount, then that's going to feed back to the pituitary and say, hey, we have enough of this. We don't need any more. So it's going to stop that process. And that's the mechanism of puberty blockers. So instead of having the estrogen or testosterone that's going to do that feedback inhibition, we're introducing a molecule that's going to bind to the receptors instead. And it's going to give the feedback signal of, hey, we have enough. And so that's all you're doing. You're just blocking those receptors. And so then the rest of the body thinks we have enough sex hormones. We're not going to make any more. And so it stops. So it's really interesting, actually, because initially you get a huge, so that was kind of an oversimplified. What the nuance of this is that it doesn't just do that, but the hormone actually stimulates more sex hormone. And that's how it tells it to shut down. So you're going to initially produce a lot of estrogen or a lot of testosterone to get that feedback process to inhibit itself. So you're using your own biological mechanism to do this. And it sounds very scary, but this is what your body already does. It's nothing out of the ordinary. I know we had a couple other questions about the puberty blockers, so maybe I want to address those along with this so I don't get carried away with.
Yep, I'm going to go ahead and. But I actually have some from the chat as well, but I wanted to say thank you, Farron Salas. Okay, I'm going to try this. Huzzah to the tippa.
Yes, this is from my trivia nights. I don't know if you've been to a Renaissance festival ever. Yes. But they say if you tip them at the Renaissance Festival, they say, huzzah to the tipper, and then they all cheers.
Oh,
so that's what I do whenever somebody contributes financially to my Twitch. I say, huzzah to the tipper, and then we all cheers.
Oh, fantastic.
And you go to mini Renaissance fairs, or you no?
I go to like one at least once a year.
All right, so we have the first question. Aunt Jur asked about Lupron, are there common side effects that are barriers to prescribing it? I asked because I took 1 to 2 doses for endometriosis and had to quit because it gave me migraines. Is that common? That's a very good question.
Potentially. I don't know off the top of my head what's the most
prescribe
common...
Aimovig.
Yeah, I don't know exactly the most common side effects to Lupron. I know kind of the biggest concerns that people have, we'll get into in a second. But of course, like the big ones people talk about are like essentially menopause side effects, because you're essentially inducing menopause to people who have ovaries. So you'll get things like hot flashes, maybe you'll get all that fun stuff.
Let me tell you, that's awful. It's awful, y'all. No joke. You don't want to do that. All right. The next question is from Titan. Titan Uranus. He's always wanted me to say that. See, I did it for you, Titan. What, if anything, would puberty blockers do to or for an adult?
I mean, probably nothing, because you're not in puberty. So, I mean, maybe if you do enough, like you'll get those menopause symptoms. Like if you can get enough estrogen stimulation to suppress the pathway, you'll just basically simulate a hypogonadism. So like in a male, this would look like low androgen, so like low T. You might have some fatigue, some that kind of thing. But I have a lot of thoughts about people just prescribing testosterone to cis men that all have fatigue, because that's also a common thing. People just show up and say that they're tired all the time and get testosterone, which is another example of where gender affirming care is available to cis people all the time, because the amount of low T centers that you have for people that just say, hey, I'm tired sometimes, give me testosterone, and they'll just prescribe it is pretty incredible. But for a puberty blocker, you cannot block a puberty that isn't happening. So you might get some effects of hypogonadism, but otherwise you're not going to suppress a puberty you're not undergoing.
All right. Before we go on to other questions, Bree, I wanted to make sure that you had an opportunity to get out anything you wanted to get out. Do you have anything either to say or any questions that you want to ask?
I think I've asked all the questions along the way that I had in mind, but I think I'm interested to hear what Ben has to say about the rest of the questions we have lined out. Or did we get through them all? We didn't get through them all, did we? Okay.
No, we have more. We have quite a few more.
Okay.
So what are the arguments against puberty blockers?
All right. So this is a fun one. A lot of people will say that bone density is the big thing. But this is all very dependent on what you're doing and how you're using these medications, because it's not just you're using this or you aren't. And Bree would know this, that there's certain factors that play a part, such as the dosage. The duration is the biggest one for puberty blockers. How long are you on this for? And there's variation with what particular doctors will prescribe, because the consensus will always lag a little bit behind. It's always going to be more conservative because of the fact that you want to be confident in what you're prescribing. So the current guidelines suggest that there's a safe window up to 2 years on puberty blockers for bone density related issues. Some studies I think now are looking at 4 years, but since we're not quite there yet, I'm going to stick with endorsing the current guidelines, but just know that these might change in the future just as we learn more. And it's not, when I say that these guidelines are changing, it's not because we don't know anything about it, but it's just we want to be within a good level of confidence for what we're prescribing. We want to make sure that people are being safe with what we're giving them. So this is even what's happening with a lot of birth controls right now. Like we'll study a certain agent for a few years and we'll say, I'm fairly confident that this is going to be more beneficial than harmful for this duration. It's probably going to work longer, but this is what we can confirm for right now. So like the Nexplanon is a great example of this. Like Nexplanon was initially approved for, I think, 3 years. They said it was effective. And then now they're saying it's effective at 5 years. And it's not that the Nexplanon changed. It's just that now we have confirmatory data that suggests, yes, we can extend this out longer for the general public. So note that these guidelines might be violated by certain doctors based on your particular medical case and based on the new data that's coming out. But I'm going to give the conservative guidelines and say that about 2 years has been pretty much confirmed to be safe. And the idea is that bone density is an issue with estrogen or testosterone. So they both promote bone density, where people will argue about testosterone giving you more bone density. It's kind of a meaningless discussion, because the reason why you get bone loss and osteoporosis in menopause and postmenopause is because of lack of estrogen. So estrogen does improve bone density, and so does testosterone. So as long as you have one of those two in physiologically appropriate amounts, then you're going to have pretty good bone density. So what we're noticing is that people on puberty blockers for 2 years or less are not going to have the bone density issues. And the goal is, of course, to either take them off the blocker or put them on cross-sex hormone therapy. And when we do that, when we put them on cross-sex hormone therapy, that's going to negate the bone density concerns. So it's really a non-issue unless you're going beyond that safety window. So as long as you're using it appropriately, not much of an issue. Kind of the one like bigger concern that like would really need to be discussed is that with some people that are assigned male at birth, if they want to undergo vaginoplasty, there's potential that since you're delaying puberty by a little bit, there's potential that your genitalia might not grow as much. And so there might be potential that you might not have as much tissue to work with. And we're not saying that this would be the case for somebody who is on a blocker and then goes to estrogen therapy or progesterone therapy, because they're not undergoing a male puberty to stimulate genital development. So that's a case where they might not have enough tissue to undergo certain vaginoplasty procedures. But it's not going to inhibit somebody if they are on a blocker and then get taken off the blocker. They're still going to undergo their same genital development. So they're still going to develop as an endogenous male would. So it's not a concern if they're going to be taken off the blockers, but it's more of a concern if they're going to go on HRT and want surgery. So
can I ask a question? Wow. I don't know if you'll know this or not. Is Testopel, is that approved for trans men to use? Is that
I don't know. Is that what's the generic? As I'm guessing,
it's the implantable. So
the implant.
I don't have a generic name. It would have a code.
Yeah, I don't think it's approved yet for trans guys at this time.
Yeah. Okay, I was just wondering about that because
I haven't heard about it being approved, so I'm gonna guess no. Maybe it's in development, but
interesting. Okay, that's all I had.
Okay. All right. So our next question: do puberty blockers cause infertility in adulthood?
So no. So, and this is where, again, we have to clarify the differences between puberty blockers and cross-sex hormone therapy, because with all of these, like I said, even with that previous example with genital growth, that is not a consequence of puberty blockers. That's a consequence of HRT. So a lot of the side effects that we're talking about are side effects of HRT and not of puberty blockers, which is why we want to use the blockers so that we don't put them on an irreversible HRT. So there are some effects of HRT that are reversible and some that aren't. For trans men, a lot of the effects are irreversible because voice changes, genital growth, because trans men do have genital growth after HRT. That is irreversible. A lot of hair growth can be irreversible. So you do have to consider those things. And fertility issues are something that you see with HRT because you can get some gonadal atrophy in both sides. So in people that are trans feminine, you can see some testicular atrophy with that. And you can see kind of a similar thing with the ovaries in trans men and trans masculine people. But that's with testosterone or estrogen / progesterone therapy and not necessarily with the puberty blocker. So that's actually a really good reason to use blockers and not just go straight into HRT.
So the next question, why are puberty blockers so controversial?
I think they're controversial because people don't understand what they are, and they hear because the term puberty blocker is kind of inflammatory anyway, because it's not really a blocker, and people assume that we're doing irreversible changes, and that's not at all the case. Puberty blockers are 100% reversible as long as you're not going on HRT after it. So it really shouldn't be controversial. And it's just like people wouldn't consider treatment for precocious puberty controversial. That's not at all controversial. But it's because people don't understand pharmacology and they don't understand biochemistry. They don't understand physiology. So it does sound scary. And what needs to happen is people need to not Dunning-Kruger their way through medicine because it's more complicated than they think. I actually had a comment on one of my videos not too long ago that was, is somebody basically trying to say that, like, I'm scared of, like, I just watched your video on puberty blockers, but I'm scared of puberty blockers because my brain connected the dots between this and steroid abuse in athletes. And I was like, hold on a sec. Like, your brain did a logic and your logic was flawed and you don't know what you're talking about because these are completely different processes. They have similar results, but they're different processes. So we cannot equate them as therapies. So try to, like, be careful when trying to intuit. Like, science is something that, especially, like, don't try to use your intuition because you're probably wrong. Like, just learn about it.
And the same formulation they used to sterilize prisoners, Lupron or whatever. I hear that all the time. They're not using the same formulation of Lupron when they're doing a sterilization as they would for doing cross hormone or any kind of
Exactly.
gender related treatment program. Yeah.
Well, and that's important too. I forgot to mention with the whole timeline of blockers and HRT, the timeline's very, very important because with that 2-year window, you're going to eventually probably move to HRT, and you can, that 2-year window is for puberty blockers in monotherapy. So that's talking about if you're using a blocker by itself. You can use it longer and mitigate the side effects with HRT because you're going to get rid of the bone density issue and all of that with HRT. But you can keep the blocker on and just titrate the level. So when I say that, you're going to change up the amounts. So you're going to start off with probably more puberty blocker and less HRT. And then you're going to change that ratio and get gradually higher HRT and less puberty blocker because you want to give the child a developmentally appropriate puberty. You don't want them to have the puberty, if they're 12 years old, to have the puberty of a 17-year-old. That's not going to work well for them. And also with testosterone, especially for trans men and trans masculine people, is that testosterone by itself in adolescent doses is not enough to suppress menstruation. So you need to give a blocker in conjunction to suppress menses while you work up the testosterone level. Because you don't want a grown man's level of testosterone in a 12-year-old body. So so that's where there's a lot of nuance here. And I think that's also why it's very controversial, is because people don't think about the nuance. And when, again, they think about it as all or nothing. When you look at, like, how are we going to apply these guidelines? I've just mentioned a whole bunch of scenarios, like, how long are we doing this for? What dosage are we using? Like, how old are they? What is the goal?
Titration is the key word.
Exactly. And it's an individual basis. And that's why you're going to have a doctor doing this. And even a puberty blocker, like, while HRT can be done by pretty much any physician can really do those, like, primarily a family medicine physician, an internist might do it, or an endocrinologist might do it. But, like, you have a broader range of people that can do that. Puberty blockers are probably going to be done by an endocrinologist unless you're really overly confident in yourself as a primary care physician, because that's some nuance that is kind of sketchy to get into that I would rather an endocrinologist handle. But so you're going to get an expert opinion. If you're going to get a puberty blocker, you're going to be seeing a board certified endocrinologist or pediatric endocrinologist for that particular issue.
Oh my gosh, well, first of all, I love my endocrinologist, and it's not even for these things. Again, gender affirming care. I really quickly, because it's about 5 minutes to an hour, and I wanted to find out, first of all, would you like to continue on and hit some more questions, or do you have a hard stop?
I don't have a hard stop. We can continue the questions.
How about you,
I guess
Bree?
I've been ranting more than usual on some of these topics.
I'm so glad, because this is such great stuff. I'm just loving it. Bree, how about you? Are you okay with going on?
I'm good for a minute. I'm going to get hungry here pretty shortly, though.
Yeah, me too. We both, Bree and I, we like burst in the door from work and grab our stuff and come on here. So we hardly ever get to eat beforehand. Okay, so our next question. We've talked about some of these, but I bet that there's more that we haven't talked about. I think there are some serious consequences if we refuse puberty blockers, and I'd like for you to kind of talk a little bit about that.
Absolutely. And this is because, as I said, puberty blockers are reversible, and HRT or your own puberty are irreversible processes. So for people, especially those that undergo a male puberty, more of those changes are irreversible than not, and it can be incredibly detrimental psychologically, emotionally, sociologically, physically, just all around detrimental to that person's well-being. And if we can prevent that, I mean, the number one pillar of medical ethics, right, is do no harm. And I hear people throwing out that term a lot of do no harm, don't cut off healthy organs, and like don't do like, no, you are not meeting that definition, because if we're talking about do no harm, if you see somebody, and especially in these adolescents that we're giving early therapy to, these aren't people that are on a whim choosing gender affirming care just because they feel like it. Like, that's, you can do that if you want to do that. You're probably going to end up getting it as an adult, because there aren't those signs there of we need to, because essentially what you're doing when you're intervening with a child is you are making consent for them because they cannot consent. So you have to think legally about, are the interventions that I'm doing, is it appropriate for me to consent for this minor to have that happen? And so you have to think a bit more deeply about what you're giving to a minor. And so when you're giving an adolescent blockers or HRT or anything, it's often they have pretty severe gender dysphoria, or they have some significant evidence that this is the right step for them. And so we're not saying either this person lives as a healthy man or a healthy woman, whether it be cis or trans. We are saying, like, either they're going to live as a healthy trans person, or they might not live into adulthood. Like, that's the debate you're having there. And that's a case where, yes, it probably is worth it to consent for the minor and make those decisions and intervene at those earlier stages. So the consequences in those adolescents who have severe dysphoria and who have high mental health risks, the consequences are, like, speaking like to the worst case scenario, is them not living to adulthood and even not living to their teenage years. And I think, like, that's a false dichotomy we need to address, is you're not comparing a healthy cis person to a healthy trans person. You are comparing themselves as a healthy trans person to a dead closeted trans person. And that's what you're weighing out here. So
Whew, that is very powerful to be talking about, because it really is. I don't think people really think about it, or I don't think cisgendered people really think about it. And that's from a place of privilege again, that we don't think about it being a life and death issue. It almost seems like to a lot of people that don't understand this, like it's just an elective thing, but in a sense, it's really not. Would you agree?
I would agree with that. And it's not to say, like, you can absolutely, if you are a person that, like, you want to do something electively and you don't have dysphoria or you don't have the mental health consequences, you are still absolutely allowed to consent for your own medical procedures. So, like, that's in no way invalidating anybody that wants to do that. Because, like, I'm in favor of the informed consent model, especially for adults. You have the absolute right to make whatever decisions you want for your body. End of story. Yeah, it's that nuance of, you add a minor and where can they consent, where can they not, which makes the evidence all the more powerful and all the more reason to do it, because you're just getting you're catching that higher risk population at that age group.
Okay, so now we're kind of transitioning a little bit out of the puberty blockers alone. But something that you said when you were talking about this it goes right into this next question, and then I have a question for you that's kind of related to it. And I hope I don't forget it in the meantime. Are there any long-term health effects associated with hormone therapy or sex reassignment surgery?
Yes. So like I was saying, a lot of consequences with HRT are irreversible. So like my voice, the way it is now, like if I were to stop testosterone tomorrow, I'm not going to have a feminine sounding voice. Unless I do voice training, but that it'll still be different than my original voice. That's something I will not change. My like surgery, of course, like I had top surgery. I'm not going to grow breast tissue back. So there are irreversible consequences of those kinds of things, which is why it's very important to discuss with people and to really think about for yourself what you want. And you should be like physicians should be transparent, absolutely transparent about what the risks are, because you should have the right to make your informed opinion. You should say, hey, if you like a big one right now for people not being able to access hormone therapy in certain states. If you've had bottom surgery, for example, like if you were assigned male and had an orchiectomy, so you don't have testicles anymore, and you are denied HRT, you're going to have minimal testosterone production, and you're going to have probably significant bone density issues. In that case, kind of, it's interesting when we say like menopause for the female side, there's also kind of menopause. Like people actually do go through an equivalent menopause in older adulthood. So you're going to get kind of those symptoms or symptoms of hypogonadism, symptoms of bone density issues, osteoporosis, a lot of that, of course, fertility issues. But that's again, like that's some risks if you have surgery and you do not get on hormones or you do not get to have your hormones. So it's very important that we allow people to have these hormone therapies because if they've already had surgery, they could have significant health consequences from being denied that. But other long-term effects, kind of a big one for both sides of the coin is you do get some risk of blood clotting issues because of it increases your red blood cell count. So you really have to watch, and that's something that your doctor's going to watch for you. When you're getting hormone therapy, you should be getting labs done every 3 months or so, and then they'll monitor your hematocrit. And if it's above a certain level, you need to dial back because there's risk of blood clots. Otherwise, apart from that, it's really safe. And for gender affirming surgery, there are a bit more risks just from the fact that it's a surgery, not necessarily that it's gender affirming. It's just because there's always infection risk. There's always risk that you won't wake up from anesthesia. There is risk for pain, bleeding, etc. All issues with that. With genital surgeries, there is risk of urinary issues, those kinds of things. So it is important, again, that you, if you want to undergo any of those procedures, that you give informed consent and that you know all of those risks. They will tell you exactly what these risks are. Not all of them are common, but it's important to know about because it can happen.
Okay, so that leads, not the sex reassignment surgery, but the long-term health effects. I've this is something I've wondered for a long time. I've heard that with women going through menopause that get onto hormone replacement or hormone HRT, trying to get the word out, that they have a higher risk of cancer. First of all, is that true? And if so, then how do we think about that with HRT for transgendered people?
It depends. It depends on a lot of factors. It's really not that much higher of a risk because of the fact that you're going on physiological levels of estrogen in that case. So you're on the same amount that a young woman would have. which is not, you don't see young people with disproportionately high levels of these cancers. So it's really not a whole lot to worry about unless you have a genetic predisposition to very specific cancer types. So if you have like cancers that are receptive to estrogen, then yeah, you might be at a little bit higher risk, but that's something that you'd have to talk with your doctor and maybe a geneticist about if you have concern about having BRCA mutations, etc. But there are some other things, like with regard to cis people and hormone therapy and osteoporosis and cancer risk, there's a whole bunch of different drug classes we end up using. Estrogen's not usually a huge problem. Progesterone's not usually a huge problem. But if you do have some of those higher risk cancers, there are some methods now called SERMs that we're using. It's selective estrogen receptor modulators, which they are estrogen agonists. So they increase estrogen activity on some tissues, but are antagonists on others. So some of them will be agonists on bone tissue, so they'll strengthen bone density, but then also antagonize estrogen effect on breast tissue, so actually decrease your risk of breast cancer. So it depends on what route you're going. And actually, there's some interesting studies coming down the pipeline. I haven't seen results from them quite yet, but on SERMs for non-binary people, who specifically who are assigned male, if they go on these selective estrogen receptor modulators, that they could get estrogen activity in like fat redistribution, but not get breast growth. So for people that want to be more androgynous, that is a potential option coming down the pipeline. That's still being studied. I haven't seen much about that yet.
That's fascinating. That's super fascinating. Okay, we have a question from the chat. And I think this is one that we still need to get consent to even ask.
Oh, definitely, definitely. I mean, I haven't had bottom surgery yet. From what I can tell, for most people, especially if you have a good surgeon, you're still going to have pretty good erogenous sensory function. So especially now, the procedures are getting very, very good to where they can nerve graft very well for trans men. And for trans women, I think it's a bit easier to keep their erogenous sensation because they are manipulating the nerve, but they're not doing a whole lot of grafting with the erectile tissue. So at least everybody that I know that has had bottom surgery, like that has had a vaginoplasty specifically, has had good results with their sexual function. I think there's still, depending on which masculinizing surgery you go down, it depends, because there's some that will use certain grafts and some that won't use any grafts. If you get metoidioplasty, which doesn't use any grafts at all, it's just a release of the clitoris from the surrounding area to what you've already grown from testosterone, that you're going to have the same sexual function because you're not changing anything. But with phalloplasty, it depends, because I think there's less likely to get nerve sensation with a thigh graft versus a forearm graft, and they're seeing that forearm grafts are doing really well. But it's very dependent, and I think there's a lot of work still going on about phalloplasty. But that's what I know. Again, like, these are just my opinions. I haven't had surgery yet, so I don't have my own personal experience.
So we have one last question, and I think that this one is super, super important for all of us that are not transgender. How can we be supportive of transgender family members, friends, or significant others?
Absolutely. The biggest one that we already talked about is consent. So make sure that when you're talking to people, that you are getting their consent to ask them questions. And like Sunny was saying earlier, that you don't demand they answer your questions, or that you don't demand they talk about trans issues all the time. Like, be open to their needs. Like, I mean, a big one, if you don't know how to support a specific person in your life, you can ask them, how can I best support you?
Mm.
And they might be more than willing to say like, hey, this is what I specifically need, because all of us are very different. In terms of the general community, there's a lot of general things you can do for all of us, such as vote. Please vote. Please watch shows like this. Get expert opinions. Go to the AFP, has some good stuff. The AAP has some good stuff. Pretty much every medical organization has a consensus that gender affirming care is legitimate healthcare. And if you want to learn more, always learn more about the issue. Don't Dunning-Kruger your way through discussions. Be willing to listen. And if there's somebody that, you know, doesn't understand something, you can send them to shows like this where we can answer those questions. But otherwise, I mean, like, you can respect people and support people just in the same way that you respect and support anybody else in your life. Like if you ask them like, hey, how are you doing? Like, and if they tell you like, hey, I'm doing okay, or like, hey, this is something I'm struggling with, or whatever. And then like, hey, what do you prefer I call you? Hey, like what pronouns do you use? All that, like it's just standard things that you should be asking every person. So I mean, just treat them like you'd treat anybody else, just with kind of that acknowledgement that maybe they don't want to talk about trans things all the time. Maybe they don't even want to like have that be part of a conversation ever. Maybe they just, there are plenty of times where I don't even want to be perceived as trans and I just want to exist as me and I don't want to talk about trans rights. So just, I mean, take it as it comes with certain people in your life, but the general things you can always do on your own, and then just be respectful of people around you.
I love that. That you're absolutely right. I just thought of another question, and it's because of the work that I do, which I don't talk about specifics about my work, but I have talked about the work that I do. So for those of you who don't know, I work with children who have disclosed physical or sexual abuse. And one thing that we do, we work with law enforcement and social services and the district attorney's office and the school system and so forth. From the time that the disclosure is made all the way through until it's adjudicated. And then beyond that, because we're doing therapy and so forth. But we've been having a lot, and we're in a very, very conservative, oh my God, Trump ass crack land, I swear. But we have had a lot of children that we've been in doing a forensic interview, and we always ask them what pronouns they would like for us to, but especially for the little ones, we just say, what would you like me to call you? Because they don't really understand pronouns, but especially the teens and preteens, we always ask them, what pronoun would you like me to use with you? And we have a lot who have come out to us and then say, but don't tell my parents who are in the other room, or don't tell my foster parent, or don't tell, whoever the caregiver is. How would you handle that? How do you think we should handle that? That's just it can be a little sticky situation for us sometimes.
Yeah. I'm in the camp that if the child does not want to tell their family, that you should not tell their family. Because it's like a case, like I know a lot of people want to say that parents have rights to know all this stuff about their children. Well, actually, no. And Sunny can probably back me up on this, that there's certain cases where we go against parental wishes, and primarily in cases of abuse or suspected abuse. And this is a case where there could be potential abuse. So this is where it's like, and with other things too, like in most states, at least the states where I've learned where I've been learning medicine, adolescents and even children have the ability to consent to some medical procedures without notifying their parents. And one of these is STD testing, because of the idea that adolescents are less likely to receive care if their parents have to find out. They're not going to come disclose that to you if they think you're going to tell their parents. And it's a greater good to get the child tested and get them safe than it is for their parents to know. So that's a case where they have full autonomy in whether or not they get STI tested. And similar things with pregnancy. You have, as an adolescent, you have the ability to consent to your baby's medical needs, even though it's ironic because you're not able to consent to your own medical needs. In some states, a lot of states say that if you're pregnant, you now have medical autonomy because you're technically like emancipated at that point. Some states are sticky about that, but there are cases where adolescents and children do have medical autonomy. And this is a case that I would argue, due to potential for abuse, they should have more autonomy in that.
I could not agree more. And that is the policy that I put forth for my staff. If a child says that, we are advocates for the child. We're not advocates for the parent. We understand that they have rights, but we're an advocate for the child. And so if they say, don't tell my mom, then we're just not going to tell their mom or tell their dad or tell their whoever is out there, because we take their care very seriously. I want to show, again, Skeptics and Scoundrels. Thank you so much for the $5 super chat. Thanks for taking the time to educate us and combat ignorance on this topic. I learned a lot tonight. So did I. Thank you so much, Ben. I do have one more question from the chat, if that's okay with you.
No problem.
All right. So AK Tanker asks, does DoD support gender-affirming care in adolescents? Service members can receive it.
Yes, they do. In fact, was on an audition rotation in my 4th year of med school. So my first audition rotation, my first patient on my audition rotation was a 15-year-old trans man seeking contraception. And it was an amazing encounter. Actually, I've actually had nothing but good experiences so far with, at least I can only speak for family medicine because that's my department. But DoD family medicine is absolutely great with gender affirming care for everybody. And I think pediatrics, I'm guessing, is also on par with that, and psych is also probably on par with that. So the DoD is actually doing a decent job for gender affirming care, actually across the board. It's surprising. I can't really talk about it on the show, but if you want to know more off air, anybody, there's some ways that the government's actually doing a better job than a lot of civilian facilities. So that's a whole separate topic. So
awesome. So we've gone way over, and I just want to thank you so much, and I want to thank Bree as well, because I know she's hungry, and I don't want to get her hangry. But
this is not here yet. I ordered it a minute ago, and I had my phone out. I said because somebody's mentioned, I think it was Purple, mentioned something about shrimp in the side chat there, in the live chat. And I'm like, oh my gosh, now I have to order shrimp. So I ordered shrimp tacos.
Gonna eat some water bugs.
Yeah,
water bugs, exactly.
So do you have any final comments, Ben?
No, I think I talked about a lot of different things. Oh, I guess I did want to mention for the people in the audience, if you listened earlier on in the show where I talked about sociology a whole lot, and I'm not a sociologist. I do not claim to be one. Like, my knowledge of sociology is like undergrad level. So eventually I'd love to talk to a sociologist into more of this nuance, but like, gender is so complicated, and even at the lower levels, it's very complicated. But there's a book that I've been reading, and it's a textbook. It's an undergraduate level textbook about sociology and gender. And if you want to know more about that, you can read this book. And actually, it's interesting because they talk about trans issues a little bit, but this is primarily an entire book about like cis people and their relation to gender in society, which is so complex. So if you want to know more about how we find out what our gender is, where does gender come from, how does gender work in society, what do we do about it, that's a great place to start. And there's plenty more than that. That's just like the tip of the iceberg.
Very good. I'm so glad that you shared that. So if you like the type of conversations that we had tonight, and you want to see more of this, please remember to like, subscribe, share, hit the bell, all those good things that are free to do, but really, really help us a lot. But if you really want to help us in a deeper way, consider being a Patreon. And I want to show our patrons now: Sydney Davis Jr., Erica Zoles, Tara S. Ryan, Tara S. and Ryan, Deneen Murphy, Dan D., Michael Wiseman, Kathy Cotton, Cindy Plaza, Sunny Shell, Aaron Colson, and Phil Calderon. Thank you guys so much. We really appreciate it.
And don't forget to check out our other shows on Skeptic Haven. We have Secular Soapbox on Wednesday night. We have Thursday's show, which is me and Sunny here at the Sunny Spot. And then Saturday, we have the Global Atheist and Women Atheists Unload. And on Sunday night, we have, or Sunday evening, I should say, we have Let's Talk, which is our call-in show. So check any of those out if those interest you.
Absolutely. And I do want to highlight our shows that are coming on this Saturday because they are really, really good. So the first one that we have is, hold on, if I can get it up. If I can get it up, that's a funny thing to say. Well, come on. Okay, here we go. I finally found it. Okay, on the Global Atheist Show, we have Starsky and Dick Dawson. It's a Ukraine talk. And then on the Women Atheist Unload, we are talking about Florida and the anti-human rights. It's a panel with Cynthia, Cindy, Stephanie, and myself. So be sure and check those out. In the meantime, until you see us again, always remember to think critically. Good night, everybody.